So the presentation's entitled Leave No One Behind, Caring for the Incurably Ill and Dying as a Global Health Priority. And I'm going to talk about various things today. And the presentation, I think you might have seen in the description, is going to be split into sort of 3 different phases, which I'll point out as we go along. But the place that I would like to start with, if anyone's brave enough to venture any comments or thoughts, is what do you feel is the relationship between medicine and death? I know it's a bit scary to speak up, but if anyone has any thoughts they'd like to share, anything is welcome. And if not, I can orient you guys.
I suppose often in like medicine, like we treat patients to try and prevent death or like stop people from dying rather than seeing dying as, which is like a good thing definitely, but also like sometimes we don't see it as like a natural process that is inevitably going to happen.
Yeah, so I think that's a very insightful reflection. I think there's a lot of rhetoric and even in like the discourse that's used in sort of like saving life in medicine. And of course, saving life, I'm not saying there's necessarily a problem with it, but it doesn't leave a lot of space for the topic of death. So I guess what I was trying to get at with this slide is that actually medicine and death, at least for me, when I kind of first put those two together, they kind of seem a bit like opposites because of the way that I've been taught medicine or experienced medicine in the countries that I've lived in. But actually, as kind of Christine's pointed out, okay, medicine tries to avoid death, but it is something inevitable. And I think that's what kind of got me thinking more about this topic and interested in this topic in the first place, was medicine's relationship to death, given that death is inevitable and something that probably, I mean, I know there's people working on it, but probably for the near future, not something that medicine will be able to stave off permanently in anyone. Okay, so, and actually kind of to give a bit more context to this, and I'd recommend you read this article if you get the time. It's a long read by Atul Gawande, who's famous for books like Being Mortal and Before Being Mortal, The Checklist Manifesto. He's a surgeon in the States, and he wrote this piece called Letting Go, What Should Medicine Do When It Can't Save Your Life? And there were a few passages, well, 2 passages that I'd like to read to you now just to orient ourselves to this topic, because this is actually where I started in really thinking about the place of end-of-life care and how we manage end-of-life in medical practice. So the first passage, and they continue one from the next, so I'll read through. But it's, after that, she began to drift in and out of consciousness. The medical team had only one option left, to put her on a ventilator. Sarah was a fighter, right? And the next step for fighters was to escalate to intensive care. This is a modern tragedy, replayed millions of times over. When there's no way of knowing exactly how long our schemes will run, and when we imagine ourselves to have much more time than we do, our every impulse is to fight, to die with chemo in our veins or a tube in our throats or fresh sutures in our flesh. The fact that we may be shortening or worsening the time we have left hardly seems to register. We imagine that we can wait until the doctors tell us there is nothing more they can do. But rarely is there nothing more the doctors can do. They can give toxic drugs of unknown efficacy, operate to try to remove part of the tumor, put in a feeding tube if a person can't eat. There's always something. And we want these choices. We don't want anyone, certainly not bureaucrats or the marketplace, to limit them. But that doesn't mean we're eager to make the choices ourselves. Instead, most often, we make no choice at all. We fall back on the default, and the default is, do something. Is there any way out of this? So that kind of was the first time I really started thinking about this, as I've mentioned. And then when I decided that I wanted to pursue some research in this, I kind of started framing my essential questions, my original questions, which are the ones that I've put here. They're not polished, but the things kind of I started with were, so I thought medicine was supposed to help people. Does it always? Kind of questioning, what does it mean to help people? The second is, given that we all die, why does it seem that medicine focuses on resisting death? Now, that might sound a bit like an obvious question, but it's a little bit more nuanced, I think, than I originally thought. But that was one of them. The third one was, what matters to people when they are dying or close to death? Is this universal? Does everyone on the planet seem to value the same sorts of things in the time leading up to their death? And then fourth was Gawande's, is there a way out of this, and how do we do better? So I'm going to attempt to provide some reflections on this as we go along. And just a little bit about kind of how I oriented myself in this topic in a research sense. So part of it was obviously studying the literature, research papers, books, journalism, grey literature. The second thing I did was I interviewed doctors, researchers, and policymakers whose work focused on the end of life. And then the last two things I did, one of them links to the second, was thematic analysis of the interview data. So thematic analysis is when you spend quite a few hours typing out your interviews by hand onto your computer. And then you can either do it by hand or use software. You go through the interviews and you analyze them to try and come up with a set of themes that you think are represented across your interviews. And then the last thing that I did was participant observation research in 2 hospices near to Cambridge. So that's the type of ethnographic research. It's kind of what it says in the title. It's participant observation. You observe people. In this case, it was doctors and nurses providing palliative care services and end-of-life care services, and you participate. So insofar as appropriate within that setting, you're not just standing behind with your notepad and paper all the time observing. You actually are somehow in the social situation that you're trying to observe. You have to be kind of an active player versus a passive observer. So that's kind of how I collected my data, and the data that I'll be presenting kind of in this presentation comes mainly from the literature and the theory, but I have mentioned a little bit about the interviews and what came out of the thematic analysis. So the first part of the talk is around modern medicine's approach to death. And I just want to say that when I'm talking about modern medicine's approach to death, what we'll see next focuses on a lot of the theory about Western biomedicine. So it's not universal, but I venture to say, and I may be wrong, sorry if I am, but I venture to say it's the medicine we're possibly most used to in this group. So from the theory, I think the most famous critique was from Ivan Illich, who launched a powerful attack on the medicalization of dying. And he kind of identified these 4 aspects of what had happened to medicine and in its relationship to death over time, well, over modernization. The first was a loss of capacity to accept death and suffering as meaningful aspects of life. The second was a sense of being in a state of total war against death at all stages of life. He also kind of pointed out a crippling of personal and family care, and that rituals around death and dying, which stretch back centuries, had been devalued. And he also said that there was a kind of form of social control, which is possibly quite a common critique in other types of medicine too, but a form of social control in which a rejection of patienthood by dying or bereaved people is labelled as a form of deviance. So what that means to say is that because we've sort of stopped recognising that dying is a normal thing, we almost pathologize it. We make people who are dying or close to death patients, and if they reject that, that's kind of beyond the margins of what medicine is comfortable with. So essentially, the theory overall, so that was kind of the start of the critique, and the theory overall of the past 30 years has really come to critique kind of Western medical systems as regarding death as something to be resisted, postponed, and or avoided. And I really like this quotation that describes it here, but it was described, and the 2 is a reference so you can find it, but it was described as keeping dying patients caught up in a medical juggernaut driven by a logic of its own, one less focused on human suffering and dignity than on the struggle to maintain vital functions. And then from my research, and this is mainly from interviews, I kind of found a similar thing. So a lot of the medics and the researchers and the policymakers that I was interviewing kind of converged. So this was one of my themes. This was within one of my themes. They converged on the point that that Western biomedicine, there's a perceived role of Western biomedicine in antagonizing death, and that particularly, increasingly, aggressive interventions are favored even close to the end of life. And then there was a kind of follow-up suggestion, which was that medically supervised deaths in institutions, and by institutions I mean places like hospitals, have become the norm in the West. And particularly through a few of the researchers who I interviewed who have been working, especially in Bangladesh and in Thailand, they insinuated that actually the kind of primacy of a medically supervised death is trickling also into other locations, such as the ones in which they are from and have worked in. And here's two quotations that I think kind of illustrate this quite nicely. So the first was from a physician researcher who said to me, his reflection was, "There's a culture that you deny. There's nothing called death, as if you live forever." And he was talking about the Western biomedical institution, the overall institution's attitude towards death. And then this is a kind of contrasting quotation that I'll share with you, but it was from someone working in the US, who was a physician and had been quite affected by what they had seen occurring in the US. So they said, "One could also argue that the system is also just geared towards aggressive care. So that's another argument that it's structural, market-based, and unfortunately care there in the US is about maximizing profits to shareholders, rather than actually like providing health as a human right." And that's another side of it. So I guess to kind of wrap up this little bit, we've talked about actually we're favoring more and more aggressive medical intervention towards the end of life. And it's quite easy to say that and shoot over the reasons maybe why we're doing that. And I think one of them that's reflected in the first quotation is certainly that like we're afraid of death. I think it's fair to say that a lot of people, not everyone, and certainly not in every geography or cultural location across the world, but in our society at least, I think it's fair to say that there is a fear of death and that we don't really talk a lot about dying. And that was something mentioned by the first interviewee as well. So that's one thing that perhaps is driving this. And then the other is also true that in some market-based types of care that prioritize return to shareholders, actually the more aggressive care you provide for longer, the more benefit it is, because the more money you're going to get out of it, which is quite a cruel way to think about it. And I'm not sure that any individual physician would view it that way, but actually the whole system in some countries is kind of geared towards promoting aggressive care up until the very end, because it's what's going to maximize profits. So interim summary for this little section. Have we gone from left to right? Now, the left image is really stylized, and obviously it doesn't represent the whole world or the situation as it's ever been in the whole world. But the overall point I'm trying to make here is that across time, we seem to have moved from death as something that happens to death as something that must be resisted. And from my research and from the fact that there is quite a lot of sociological, anthropological research interested in this, it really seems that medicine has played some sort of role in that tradition of our relationship with death. Okay, so that's the first bit of groundwork that's been laid. Are there any questions at this point before we move on a bit to me trying to link this to palliative and end-of-life care? Okay, then I'll move steadily on. So, okay, we've talked a little bit about medicine's relationship with death. What about palliative and end-of-life care? Where do they fit in? And this is going to address, by the way, you probably won't remember them, but if you look at the slides afterwards, if you want to, it's addressing questions 3 and 4. So palliative care first. So the WHO defined palliative care as a branch of medicine that seeks to improve the quality of life of patients and their families as they face the problems associated with life-threatening or life-limiting illness. And from an interviewee who was on the Lancet Commission for Palliative Care and Pain Relief, they define palliative care essentially as a response to suffering. If you remember a few slides back, one of the criticisms of modern medicine was its inability to accept suffering as a normal part of life. So I initially want to point out here that a response to suffering is both a great answer and something that we have to think carefully about, because not all suffering is bad, and not all suffering will be perceived by the suffering person as bad. So whilst palliative care is, and personally I feel should be, a response to I guess, unwanted suffering, we can't assume that all suffering is bad and not wanted. So that's just caveat number one. So what does palliative care look like more practically? So as we've established, and with the caveat, it's the prevention and relief of suffering. That's the principal aim. And it's kind of done in two ways. The first is through the assessment and management of physical symptoms and pain. And the second is a holistic approach to the psychological, emotional, social, existential, and spiritual needs of patients, which are a lot of words, and they may sound similar, but they are subtly different. I won't go into great detail here, but you can read more about it if you'd like. The point that I'm trying to make here is rather, and I've drawn a really haphazard balance, but it's a balance between the two. You can't just, when you're thinking about palliative care, you can't just orient yourself only to the physical symptoms and pain. It also has to include all the other components, which have been shown time and again to be important to people as they near the end of their lives. And actually, to be honest, throughout life, but it's always been a bit of a curious reflection of mine that I always feel like the things on the right of the slide, the holistic approach, should be something that we provide to all patients throughout the life course, but it is actually something that's only really placed an emphasis on when people are approaching the end of life, which is an entire research question in itself, but maybe something worth thinking about. And end-of-life care is included within palliative care, but it's only one aspect of it. And it focuses on the care of people who are nearing the end of life, specifically for those who are thought to be in the last year of life. So actually, there's 2 points that I want to make here. The first is that end-of-life care is not only for people who have an illness that will imminently or acutely cause their death. End-of-life care is something that people who say are dying through the natural process of old age are entitled to, of course. And the second is just going back one slide. One reflection I'd like to provide, because it's easy to fall into, palliative care is most traditionally associated with the hospice movement, or at least here in this context, with the hospice movement and with dying patients. But palliative care, as per the WHO definition, is not only for dying patients. In fact, there's lots of patient populations who are not dying, but who may live with life-threatening or life-limiting illness, who require and benefit from palliative care. And one more example is, sometimes you have conditions that actually are not life-threatening at all, but that also can benefit from palliative care. So one example is, if you sometimes you might have had a cancer and you've had an operation to remove the cancer, and they've also taken out the nodes that filter fluid, say in your arm. So if that's happened and you can't filter your fluid so well, you get a buildup of fluid, for example, in the arm. And that's called lymphedema. That's the fancy word, but we don't need to worry too much about that. But the point is that within palliative care services, for example, would be included massage techniques that are known to relieve fluid buildup, because essentially what you have in your arm is an incurable fluid buildup. That's not going to get better because you no longer have these nodes. And that's still within palliative care, and the person does absolutely not have to be sort of approaching their death in any way for that to be appropriate care for them. So just a common trap that people fall into thinking that I wanted to point out. So why is there a need or a role for palliative and end-of-life care? Well, there's been quite a lot of research done, and the term that's kind of studied here is serious health-related suffering. And it was shown that it was estimated that 25.5 million people of those 56.2 million who died in 2015 experienced serious health-related suffering. And that of these 25.5 million, 80% lived in low and middle income countries. And it's also projected that if current trends continue, by 2060, 48 million people will die each year suffering, with the largest proportional increase occurring in low and middle income countries. And this is suffering that could be relieved appropriately by palliative care. Now, again, we've talked about the kind of nuance of suffering. That doesn't mean you always want to label serious health-related suffering a bad thing and you always want to get rid of it, but that actually in the majority of these cases, there probably was and is scope to make a positive contribution to people's quality of life and reduce their suffering in a way that's appropriate, that's not happening. So to kind of link the first two parts of the presentation together, essentially what we've come to is that in some geographical and cultural locations, there's practice that doesn't know when to stop. And in the other, or in other practice overall, there's suffering that could be relieved appropriately. That's our caveat. There's suffering that could be appropriately relieved, but is currently not being addressed. And the kind of idea is, well, could effective and greater palliative and end-of-life care somehow provide a helpful middle ground for this? Essentially, we're thinking here about their being able to judiciously reduce suffering, prioritizing holistic interventions as per the needs we established earlier that favor quality of life, and bring some sort of acceptance of death more back into the heart of medicine, particularly as medicine progresses across the globe. And again, I try and be quite critically reflective of even things that I feel positively about. So what do we need to be careful of? One of the criticisms, and this goes back to Illich, is treating medicine's failures with more medicine. So we need to be really careful that we're not just applying more kind of biomedical solutions to problems that can't necessarily be fixed by the giant bowl of biomedicine. And then the second thing is, and it's something that I'll come back to later, but there is a risk that the psychological, social, emotional, existential, and spiritual needs of patients get left out because they're harder for some types of biomedicine. So I think for those of you that are medics or who do get to sort of work in a palliative care context, even in the UK, from my observation, they do consider these things, of course they do, and they do it quite well, but the emphasis is still towards the relief of physical symptoms and pain. That's where most of at least doctors' energy goes. And again, this is possibly tipping the scale in a way that's not as holistic or not as comprehensive as we would like it to be, because all these needs that are mentioned on this slide are not secondary to physical symptoms or pain. They're as, or if not more important than those. So we need to be really careful that they're integrated into whatever palliative care and end-of-life care that we're trying to get towards. So in finding the middle ground, my reflection is that they likely can help. Palliative and end-of-life care can help, though with caveats. Mainly that not all suffering needs to be reduced and needs to be gotten rid of. And that you can't ignore this holistic approach to people. It's not only physical suffering that counts, which is something that, again, our medical systems, at least in this context, are geared towards. And we could have a long discussion about what the role of doctors and nurses and medics is. I think I come from a position, to be completely honest, and lay out my kind of conflict of interest in a way. My position is that you can't really look after people's health without physical health, without looking after everything else that comes with the person. You cannot separate physical health from people's social lives, from people's psychological state, from people's spiritual needs, because we're not separate boxes that make up a person. We are an integrated person. So I think that holistic approach cannot be ignored. And what is needed, and we'll more on this to come, but what is needed will not look the same everywhere. It's likely that palliative and end-of-life care are not at their final iteration, and that even in using them as a tool in contexts where they're well established, there's still a lot of progress to be made. So for the final part of the presentation, where do palliative and end-of-life care fit into global health, past, present, and future? We've kind of mentioned this a bit. The summary is that there seems to be a lot of suffering, if we remember slides back. There seems to be a lot of suffering, at least some of which could be appropriately relieved by access to palliative and end-of-life care, which isn't really happening. However, for many, there's an access abyss. And the access abyss was used by the Lancet Commission of Palliative and End-of-Life Care, Palliative Care and Pain Relief, that was their specific name. They coined this term to describe the current state. And they kind of brought up these three main points, A, B, and C, but I've edited them slightly. So they highlighted a lack of existence of services. I've added a lack of existence of holistic services, and you'll see why. B is a lack of availability of essential medicines, and C is the biomedical aversion to death, which I'm not going to touch on too much because we've already spoken about this. So this is one of the key maps. So this is global levels of palliative care development. And what this map is meant to show is it's meant to link to point A, a limited existence of services, to show essentially the darker color that you get, the more advanced the integration of palliative and end-of-life care is into the healthcare system, going down to this kind of light gray, which indicates that there's no known palliative or end-of-life care activity in this country. So what you can see is that nominally, I think it's fair to say from this graph and how the authors described it is effectively that the world is split down the middle, and that the global north has palliative care and end-of-life care overall at a more advanced stage of integration. So in some way, the access abyss for some people may look like actually there's no infrastructure and no services to deliver this type of care. But again, being kind of reflexive, I'd like to add one more caveat. I think there's some quite interesting research by Murray. I think I've also linked it. There's some quite interesting research by Murray who compared end-of-life care patients in, I think he covered Kenya, Uganda, it might have just been Kenya and Uganda actually, and compared them with patients in Scotland. Now, Kenya and Uganda have palliative care, but they do not have it at the most advanced stage of integration. And what Murray found and his team of researchers were that still, even though nominally in Scotland the infrastructure was a lot better, the spiritual and existential needs of patients were much better met in Kenya and in Uganda than they were in Scotland. In fact, people in Scotland routinely said, you know, my pain is under control. It was a qualitative study, so I can kind of paraphrase, but they routinely said something along the lines of, my pain is under control, my physical symptoms are under control, but no one comes to see me. I have no sense of community. I don't necessarily feel connected to any sort of greater purpose, and I'm scared about my death. So I guess what I'm trying to make, the point I'm trying to make out of this slide is actually twofold. The first part is that yes, there is a need for infrastructure, and there's a lot of countries that don't have that infrastructure, which is a bad thing. But also that, again, coming back to this point about holistic services, even in the countries that you see here that are at the darkest stage of blue, that doesn't necessarily mean that they're doing it well. That means that they have services to do something, but it doesn't mean that all the fundamental needs that patients need met are being met. So I wanted to kind of frame that when we look towards the future of palliative and end-of-life care, it needs to be a two-way transfer. It's not something that we've got like right in the West or the global North that needs to trickle down into the rest of the world. It's really something that everyone is working on or should be working on, and no one has done it right or particularly well yet. We both need to learn from each other. In fact, everyone needs to learn from each other as to how we can do the best by patients who would benefit from these types of care. This slide is more on a physical symptoms point, but I think it's also interesting because it links into the access to medicines. And again, it's a little bit complicated for a few reasons, but basically this map shows the distribution of opioids across the world. So opioids are quite popular drugs in certainly in Western biomedical versions of palliative and end-of-life care in relieving pain. And one of the things that the Lancet report commented on very strongly was that morphine is a cheaply available drug. It's off patent, and all of these reasons why that pharma companies can't really say that it's not producible or whatever. And actually that the distribution of opioids for palliative care, I mean, you can look at this map, it's completely distorted. It's mainly going to Canada, the US, some parts of Europe and Australia. so again, this is about physical suffering, but the point that they were trying to make is, and one of the interviewees who I interviewed who wrote this essentially said, we need to kind of change the way this graph looks, and we need to make sure that pain relief is available for everyone who needs pain relief, no matter where they are. And he used quite strong language. I think he found it quite outrageous that pain relief is not available in much of the world when these drugs are cheap, they're very well known, they're really easy to manufacture, and they've long since been on the World Health Organization essential medicines list. Obviously, it's not as easy as this. There is a reason why it's difficult to access opioids. One is actually because I can talk about, I think, do we have time? Yeah, I'll mention it very quickly. So there's kind of two reasons. One is something that's called opiophobia, which is not a derogatory term, it's just reflecting the aversion to opioids. Now, the aversion to opioids comes from the fact that historically they have been misused, and they have been forced by certain countries, mainly these sophisticated Western countries, for those who couldn't see sophisticated in inverted commas, down the throats of other people, and they've actually been almost used as kind of weapons of war. So there's a really complex history about opioids that can make probably quite a lot of people very understandably averse to using them. So there is this kind of context that needs to be taken into account as to why people may be very reasonably averse to using more opioids. And then the second thing is that it's a kind of access to medicines point, but if you're interested in that, it is interesting. Basically, if you need a small number of doses, as a lot of countries do, pharma companies charge a lot more to start up production, which means that the prices commanded by very small countries that don't need so much opioid are much less than larger countries. So a key example is that Rwanda pays 6 times the price the US pay for morphine. So in those 2 slides, just to recap, I've covered the limited existence of holistic services and the lack of availability of essential medicines, focusing on opioids because that's the hardest one. So where do we go from here? So to wrap up, I think my conclusions from my research were that we need more research, particularly because most research on palliative and end-of-life care has been conducted in the global north and has focused on the global north. And that's not the whole world. So we really need to prioritize research of which interventions work best everywhere, but particularly focusing on the low and middle income countries of the world and actually what their priorities are and what they need and what infrastructure would be of benefit there. The second is policy making. And I think that the World Health Organization passed a resolution calling for greater palliative care infrastructure in 2014. But I guess the priority for policy making would be some sort of accountability mechanisms into our policies. So we need to make essentially realistic policies that can produce some sort of progress with the resources, the differential resources that we have in different contexts, but also that have some sort of accountability mechanisms to make sure that actually changes get implemented. Then infrastructure ties into that, both physical and human. And again, when we're building and thinking about our infrastructure, it needs to be tailored towards meeting all kinds of needs that people have, not just physical suffering and pain. Access to medicines, for sure. And if you read the Lancet Commission report, they created a sort of essential package for palliative and end-of-life care, which lists 20 essential drugs that should be available everywhere. So that's one other project. And then the fifth one is probably, I think, the most important one, the point of solidarity, and solidarity being something that's mutual. It's a two-way transfer of knowledge, of practice and experience. It's not just an exportation of, say, what we're doing in the UK to the rest of the world, because there is much to be learned in pretty much every context. And so coming up to the final slides, I guess that this is my personal reflection. There's unlikely to be one universal good death. I really got this from all of the interviews. There's not actually one perfect death for everyone. And the uncritical transfer of practices from one context to others is unwise. And a more helpful aim, when we think about where we might go, what all of these 5 things might be aiming to achieve, is the translation of practices hoping to achieve broadly similar goals, such as the appropriate relief of suffering, but in ways that are tailored to contextual needs. And one of my interviewees came up with a lovely, I think it's a great model called value logistics, which is essentially that in particular contexts, essentially what you want to find out is what matters to people. And then the next question you ask is, what are the logistics that I need in order to meet those needs? So for example, the context in which they worked in was, and had lived in and were from, was Bangladesh. And their experience there, and it's documented in research, is there it's much more important to die in your community and around your family, for example, than to have a great deal of autonomy in your end-of-life decision-making and to prioritize necessarily a pain-free death, a physical pain-free death. And for example, in other studies, a pretty broad systematic review found that in quite a few contexts in sub-Saharan Africa, you're far more likely to die in the community than, say, in the global north, when it's much more likely that in this country, for example, that you'll die in a hospital or possibly a hospice. So the idea of the value logistics model is that you adopt an approach to palliative and end-of-life care that asks, what are the needs of the individuals in this geographical and cultural context? And therefore, what logistics can I provide that meet those needs? In some places, those will be hospitals and an emphasis on autonomy, a pain-free, medically supervised death. And in other contexts, it may well be more community-centered services that focus on actually integration of the family into the patient's care, to give one example. And in other situations, it will be both types of infrastructure that are the priority. But this model's worked quite well, and it draws quite a lot from the Kerala. I'd look at it if you have time, but the neighborhood networks for palliative care in Kerala, India, which has essentially developed a community method of delivery of palliative care that is self-sustaining and actually works really well even in the context of technologically more limited medical resources. So that was a really good thing that I learned about in my own research. So overall, I think what I'm trying to say is that we need to look for a suite of solutions versus one global future, and that palliative and end-of-life care are likely to be useful, but that we need to be kind of reflexive about how we do them and how we move forward, and that it should be a two-way transfer of knowledge and practice. We need to identify the common denominators of needs for these services, but also where requirements differ, and make sure that we're tailoring our requirements to the context in which they are to be applied. And from there, we can guide our efforts to develop culturally and locally appropriate services accessible to all those who need them, and that critically respond to all the comprehensive set of needs that patients with life-limiting, life-threatening illness towards approaching their end of their life or actively dying need. Okay, and I think that's everything. I've got a few take-home messages here that you can read, but I won't keep talking at you any longer. I think we have about a quarter of an hour